Good morning, everyone. Before I begin, I would like to thank Dr. Veena ma'am for giving me this opportunity. So I'll be talking on low-dose atropine and myopia control, a pharmacological approach. So before we go into the details, let's know what is the current scenario of low-dose atropine across the globe. So here, if we see, low-dose atropine has mostly been used in Asian and East Asian countries. And there are various studies with low-dose atropine, and the results are again varied. And this is all because of the difference in the efficacy and the safety profile due to differences in ethnic backgrounds, environmental and socio-economic influence. And again, availability is an issue. It's still not FDA approved, and so in many countries, the regulatory approval is still not available. So in the West, it's more of optical interventions that are being used. But in Indian scenario, low-dose atropine is still the easiest, cheapest, and the most accepted intervention. So, how did atropine come into place for myopia control? It was just based on anecdotal observations that atropine was found to be useful in myopia control. And the landmark study was ATOM 1 in 2006 and followed by ATOM 2 and LAM studies. So, what do these studies say us? Before we go into that, what is still not clear is the mechanism of action. Initially, atropine was thought to act through accommodative pathways. But what is now clear is that atropine acts mainly by increasing the release of extracellular matrix by the scleral fibroblast and inhibiting the scleral thinning. At the same time, it reduces the release of extracellular matrix by choroidal fibroblasts, which causes choroidal thickening and inhibition of axial elongation. And there is also this theory of increasing dopamine release in the retina and inhibition of retinal signaling causing axial elongation. So what do these studies tell us? So in ATOM 1, it was the first study done in Singapore in 2006. And in this, they studied 1% atropine versus placebo. It was used for a period of 1 year and then followed by a 1 year washout period. And then they looked at the efficacy of atropine. So main thing was it had more side effects. Though it was effective, it had more side effects, and there was a significant rebound. So then came the ATOM 2 study in 2012. Again, here they reduced the concentration now to 0.5%, 0.1%, and 0.01%. There was no placebo group in this study. And here they used atropine, low-dose atropine for 2 years. And then after cessation, they followed after 1 year period of washout. So here they found that 0.01% was more effective at the same time with minimal side effects. And in this LAM study, which was done in Hong Kong, here again, the concentrations that were studied were 0.05%, 0.025%, 0.01%, and compared with the placebo group. Actually, this is a multi-phase study. So at the end of 5 years, they found that 0.05% was most effective with a good safety profile. And we also have the iAtom study in India, which is still going on. The 1 year results are out, and in this study, the 0.01% versus placebo, and they found it to be very effective at the end of 1 year. So now that since various studies are available across the globe, so there is some consensus achieved. One by the World Society of Pediatric Ophthalmology and Strabismus. They came with this consensus statement in 2023, which was again revised in 2025. And same way, in India, we have this consensus statement derived by the Childhood Progressive Myopia Expert Group, of which Dr. Jitani sir is also a part. So based on these consensus and guidelines, we now have some idea to most of the questions regarding atropine usage in clinical practice. So normally, what are the questions that come in our mind when we have to start low-dose atropine? So what is the workup that has to be done? When to start? What about the safety profile, efficacy profile? What is the dosage, frequency, duration? When to review the patient? What to monitor? And when to stop? So we'll be discussing this now in the subsequent slides. So before we start any patient on low-dose atropine, history is important. Apart from the regular history, the history of prematurity and laser for ROP, and parental history of myopia and siblings, and the child's environment is very important. The time spent outdoors, the amount of time spent on your activities, and the lighting, the amount of lighting that is being used. And if the child is already on glasses, then when was the onset of myopia? What was the progression? if they have any biometry records with them, and if they're already on any myopia control measures. And with regard to examination, cycloplegic refraction has to be done, and axial length can be recorded with the non-contact method, either IOL master or lens star. Apart from that, if it's possible, we can get the mesopic pupil size recorded, and peripheral refraction again, whenever possible, it can be done. And ocular biometry, as it has been discussed, not just the axial length, the other parameters also have to be recorded, and binocular vision assessment, checking for accommodative parameters. So after getting all this done, now when to start? So there has to be a documented progression of myopia, a myopic refractive error of at least 0.5 diopter per year. And generally, before starting, we can do a risk factor assessment. Like based on the factors, the younger the age, the more is the progression. Same way, one or both parents being myopic adds to the risk. And myopia in siblings, and the amount spent on your activities, outdoor activities, and the baseline spherical equivalent. The higher the baseline spherical equivalent, the more is going to be the risk for progression. And low dose atropine is contraindicated in children with Down syndrome, congenital heart disease, and those on antidepressants. So before we start, for any drug, we need to know what is the safety efficacy profile. So short-term effects reported with low-dose atropine are allergy, reduced near vision, loss of accommodation, and glare. But all these effects are lesser with lesser concentrations. And also these effects are known to be lesser in Asian people, whereas when compared to the Caucasian population. And now we have long-term data also on atropine. So there is this Atlas study which came recently in 2024. So they followed the ATOM 1 and ATOM 2 participants for 10 years and 20 years. And then they found that there is no long-term ocular side effects with low-dose atropine. So coming to the efficacy part, so now it is clear that atropine has a dose-dependent effect on both the spherical equivalent and the axial length. And it also has a cumulative effect, that it is more effective in the second year of treatment. And if you can see here, this compares the results of ATOM 2 and LAM study for the different concentrations. So in LAM study, they found that 0.05 was better in controlling the axial elongation as well as the spherical equivalent progression. And same way in ATOM 2, 0.5% had better efficacy. So normally what is available in India and approved in India is 0.01%. 0.01% is commercially available in India and has been approved by DGCI. And now that 0.05% is also has obtained recent approval and will be available soon as a commercial preparation also. So, the dosage that we use normally now is 0.01%. 0.05% has also been studied as preparations. Okay. So in with regard to frequency, normally we start with once daily dosage, and those who are non-responders, we can increase the dosage to BD. And the duration of usage, is minimum duration is 2 years, but according to evidence, we can still use up to 5 years. And how to follow up these patients? So for the first time when we start, it's better to call the patient for a review at 2 to 4 weeks to look for the side effects, the pupil size, and the accommodation parameters, and then review them once in 6 months. And in this visit, in every 6 months, we'll have to get the cycloplegic refraction, axial length, and look for the compliance also. So the main issue with low-dose atropine is the compliance. So most of the time in practice, if we see about 1/3 of the patients are not compliant. Even in SIR's publication, among 27 children, 1/3 were found not to be compliant at 6 months. We also did a similar compliance study at our center. And among 93 patients, we found that 84% were compliant at 6 months. We also saw what was the reason for non-compliance. So it was found that compliance is correlated significantly with higher socioeconomic status, as well as understanding of the necessity of the drops. So based on the belief about medicine questionnaire. So more targeted counseling to low socioeconomic status population is needed. So on review, when we follow up these patients, we should find whether they are responding to the treatment or not. So sometimes, usually in low-dose atropine, about 20 to 55% of the population may not respond to low-dose atropine. So when do you call them non-responders? when the progression is more than or equal to 0.5 diopter per year after 1 year of treatment with low dose atropine. And suppose if they are progressing beyond that, then then they are termed as rapid progressors. The progression being more than 0.75 or 1 diopter. So the common risk factors for non-responders or rapid progressors are younger age of onset, both parents being myopic, and higher baseline myopia. So in these patients, actually, either the options can be increasing the frequency to BD dosage or increasing the dosage to 0.05% and considering combination therapy. So again, there's another study in India where they looked at rapid progressors and they used 0.05% and they found 62% reduction in progression at 1 year in AIMS. So when to stop? The general recommendation is when age is more than 15 years or there is no progression for at least 2 years. And after we stop, again, we'll have to follow the patient for a rebound effect. Generally, the rebound is less with 0.01%, but in higher concentrations, the rebound is more. So again, also with shorter treatment durations, younger age, and the higher baseline spherical equivalent. So instead of just stopping the drug abruptly, it can be tapered to alternate day regimen and then can be stopped. So combination therapy, I think sir will be highlighting in his talk. He'll be talking more. So in our center also, we did a study on combination therapy on 13 children who progressed despite low dose atropine usage after 1 year. And here we again used halt lenses in 10 and DIMS in 3. And we found that though there was a increase in axial length, the spherical equivalent did not change at the end of 9 months. So combination therapy, low dose atropine definitely has additive effect along with defocus spectacle lenses. And again, a role of low dose atropine in pre-myopia and high myopia, many studies are not available, but in LAMP actually they found that the 2-year incidence of myopia was less with low dose atropine. And the results of ATOM-3 study, which studies 0.01% in myopia, the results are still not out. With regard to high myopia, again, there is one study which has looked into the effect of 0.01% atropine in high myopia, and they found 77% reduction in spherical equivalent at 2 years. So to conclude, low-dose atropine is safe and effective, and it has a cumulative and dose-dependent effect. So there has to be a documented progression before initiating low-dose atropine. Counseling on compliance and follow-up is very important before we initiate low-dose atropine. And we'll have to identify the non-responders and the rapid progressors early and switch them to combination therapy. Thank you.